Dr. Wilkerman is an assistant professor at the John Jay College of Criminal Justice, and also an assistant clinical professor here at Yale University of Pharmacy. She did her PhD at the University of North Texas, did a pre-doctoral fellowship here at Yale, and then also postdoctoral fellowships at Yale, and then also at the University of Washington. She's the treatment developer of what we'll be hearing about today, which is mindfulness and modification therapy, and it's supported by the Donnelly Foundation grant, which enables her to investigate the effectiveness of this particular treatment, specifically for women struggling with alcohol use.
That sounds about right. So thank you for having me today. I have about an hour's worth or maybe 55 minutes worth of stuff to actually say in much less than that. So I'm probably going to go fast, and I tend to get excited about what I talk about and go fast anyway. However, it tends to be better if people actually, when they do have questions or comments, if they do, shout out or raise their hands or whatever. So I'll do my best to stop after every few slides and ask if anyone has any questions or comments, but if I don't, feel free to shout out or wave at me or anything like that. So I'm going to talk about the use of mindfulness for impulsivity and aggression, and then a treatment called mindfulness and modification therapy. So first of all, what is mindfulness? And there are all sorts of different definitions out there. Mindfulness is used to some extent in dialectical behavior therapy, but there are all sorts of there's lots of confusion about what mindfulness actually is. And so the way that a lot of people describe it is awareness, attentiveness, and acceptance of the present moment. In other words, mindfulness is the ability to experience and tolerate one's thoughts, emotions, and sensations in the moment without feeling the need to engage in some sort of behavior to change them immediately or turn them off if they feel uncomfortable. Now, lots of research has shown that difficulties with mindfulness play a role in disorders of impulsivity and behavioral dysregulation. I actually use the term behavioral dysregulation instead of impulsivity because a lot of times acts of aggression aren't necessarily impulsive. A lot of times, sometimes they can be impulsive, but then sometimes the person can be ruminating for hours or sometimes even days about what they will say to a person, and they still sort of explode, but it's built up over time. And same things with substance use and other sort of behaviors that sometimes people call impulsive. So I will sometimes use the term behavioral dysregulation. For example, trait mindfulness levels are negatively associated with self-reports of a whole host of dysregulated behaviors. Everything from aggression and conflict, eating disorder, substance use, gambling, overall impulsivity, and reported use of maladaptive behaviors such as substance use and self-injury as attempts to regulate emotions elicited by distressing situations. But wait, it gets better. Mindfulness is also a core component of several treatments that have at least shown promise for substance use, eating disordered behavior, gambling, aggression, self-injury, overall dysregulation, etc. But so how might mindfulness deficits play a role in dysregulated behaviors? After all, so many people think of mindfulness still as a sort of frou-frou concept. And before I go any further, mindfulness and relaxation are not the same thing. Sometimes they can be, but sometimes they can be exactly opposite. Mindfulness is being aware and being able to experience and tolerate what's going on in the moment. So if what's going on in the moment is anxiety or agitation or sadness, mindfulness is the ability to actually experience that. Whereas relaxation can sometimes be trying to change what you are actually experiencing. So doing relaxation techniques and doing mindfulness exercises aren't necessarily the same thing, although people will often report that they find mindfulness exercises to be relaxing. Does that make sense? Okay. So this mindfulness, this sort of frou-frou sounding concept, dysregulated behaviors like aggression and other impulsive behaviors can be a pretty big deal. How could something like mindfulness or mindfulness deficits play a role? Well, one of the most prominent clinical factors in dysregulated behavior is negative affect. to the extent that a lot of people actually conceptualize dysregulated behavior at least partially as an attempt to avoid or at least regulate or suppress negative affect. And individuals with difficulties with mindfulness, so difficulties actually experiencing and tolerating the present thoughts, emotions, and sensations, are likely to have particular difficulties experiencing and tolerating the current thoughts, emotions, and sensations if they're distressing or uncomfortable or have the potential to be distressing or uncomfortable. And thus they tend to avoid or suppress internal and external experiences with the potential of being unpleasant. So a lot of times they can just sort of, I'm not going to think about that, or I'm not going to feel that, or I'm going to distract from that. Chronic avoidance, however, while in the short term can make things feel better, precludes habituation and leads to the continuation and often escalation of distress. In addition, if an individual with chronic avoidance, so they're used to whenever they're anxious, they'll just avoid the situation, or if they're sad, they'll distract. When they get in situations where they can't avoid, we all have times in our lives where we are sad and we can't avoid the sadness, or we're anxious and we can't avoid the anxiety. If avoidance is their way of coping and they can't avoid, they might react with extreme efforts to suppress the experience, which could be dysregulated behaviors, such as aggression, such as substance use, such as cutting, whatever. Then these behaviors are reinforced. They cut, they scream at someone, they get wasted, they feel better in the short term. So these behaviors are reinforced until they almost become automatic reactions, which is why sometimes CBT and things like that don't seem to work that well with these people, because it's almost like the reactions are automatic. They bypass the thought process. And a lot of these clients will say, it's like, I didn't even, I hate that I said this to this person or did this to this person. And, I told myself I'd count to 10 or I'd leave the situation, but I didn't even know I was going to do it. It's like I yelled first and then afterwards I felt bad and I had no idea I was even going to say what I said. The association between mindfulness deficits and dysregulated behavior might be particularly strong in individuals with BPD. In fact, deficits with mindfulness, is difficulty tolerating the present moment, might underlie BPD features and characteristic difficulties in impulsivity, emotion dysregulation, and interpersonal dysfunction. Any questions or comments so far? Okay. For example, deficits in mindfulness are associated with, and these are some studies we did. We did it with college populations. We did it with people who were diagnosed with BPD. We did it with people who were hospitalized for suicidality. And these relationships carried across and were actually fairly similar in all three populations. They're associated with so low mindfulness, deficits in mindfulness, with increased harmful impulsivity in emotion regulation strategies, such as aggression, substance use, self-harm, etc. Increased passivity in emotion regulation strategies, so ineffective strategies. And decreased effectiveness in interpersonal functioning, and a very strong relationship to increased BPD features. And in fact, in all three populations, this relationship, the relationship of mindfulness to BPD features, actually continued even when controlling for all three of these variables, which are often thought to be the core constructs of BPD, to the point that some people, including my research team, believe that possibly mindfulness deficits are a core construct underlying borderline personality features. That's what I just said. After all, not everyone with BPD engages in self-injury or other severe acts of dysregulated behavior. Perhaps mindfulness plays a protective factor against the expression of BPD features through such behavior. So for example, with increased BPD features, there's an increased chance that people will engage in these maladaptive, impulsive, dysregulated behaviors. However, not everyone with high BPD features engages in these behaviors. So perhaps even people with strong levels of BPD who are able to, they might feel these emotion mood swings, they might feel the intense pain, but they have more of ability to actually experience it and tolerate it. So perhaps mindfulness does play a protective factor, and even people with strong BPD features are less likely to engage in these very severe maladaptive behaviors. Consistently, we've done research in individuals in psychiatric hospitals hospitalized for self-harm or suicidality that showed that mindfulness deficits mediate the relationship of BPD features to acts of self-injury and overall acts of harmful, impulsive, and dysregulated behavior. So all of that was sort of a little intro to get to the big point. How might an intervention targeting mindfulness address impulsive, dysregulated behaviors such as aggression in BPD? I mean, come on, these people are so dysregulated. Can you even get them to do mindfulness? And we're not talking about DBT kind of mindfulness where, you know, they're aware, they're observing, they're describing. We're talking about actual mindfulness exercises where they might take 5 or 10 minutes to actually just be aware of what's going on. Well, first let me tell you how we believe that mindfulness works, and studies bear us out. First, mindfulness fosters emotional processing and habituation to urges and negative emotions. So people actually start getting used to experience these emotions and urges and start learning that they can actually have an urge without automatically acting on it. Or as we like to say, urges don't predict the future. It facilitates the centering, the ability to step back mentally and be aware of other response options, which sounds sort of, I don't know, a little bit hokey, but we've actually found that a lot. Our clients will actually say, for example, we had a client who, the very first week that she came to treatment, she actually came up to our place and had just had a screaming match with someone at the front door of the hospital because she had opened the door for him and he had not said thank you or acknowledged her in any way. And we asked her why she was so upset about it, and she said, I don't really know. I was just really mad. And on further examination, she said, well, I guess he just thought, you know, that I was so worthless, that I wasn't even worth his time to say thank you to. But she said that didn't really cross her mind at the time. It just really pissed her off that he didn't say thank you or acknowledge her. Just coincidentally, the week before treatment ended, she came in and she said, you know what, I opened the door for someone and they didn't say thank you or acknowledge my presence at all. And I said, so how was that for you? I said, you know, and she said, well, I didn't yell at them, I didn't say anything. And I said, well, did you feel angry? And she said, you know, I started to, and then I stopped and I thought, you know what, it doesn't necessarily have to do anything with me. It could be that he's just rude. It could be that his mom just never taught him manners. So instead of automatically reacting, she was able to step back and actually think, okay, there might be other options, other ways not only to interpret it, but other ways for me to respond. Mindfulness also fosters awareness of increasing negative arousal in early stages. A lot of these clients, when they come in, they say, I wasn't even aware that I started having urges, or I really wasn't aware that I was getting angry. It was, you know, I was at 0 and then suddenly I was at 10. So it fosters awareness of increased arousal in early stages, so skills can be used when emotions and urges are more manageable. It helps tolerate and release shame if urges occur, if lapses occur, decreasing the abstinence violation effect, which is predictive of relapse. So if someone, you know, has a lapse and screams at someone when they say they aren't going to, or if they have a lapse and they go out and drink one night, it's less likely to turn into a full-blown relapse. I could talk literally for about 5 hours on this next one. Mindfulness enhances neural pathways involved in behavioral and emotion regulation. There's a monthly thing at NYU where people come and they talk about the various scans that they've recently shown, and it's very, very exciting, and it's not my main area of expertise, but tons and tons of research that has shown that even short-term mindfulness meditation actually changes connectivity and functioning in the brain. And then it also increases the capacity to experience positive emotions and derive a sense of meaning. So if you're wanting to take away behaviors that have felt comfortable to the clients, it helps them actually learn to appreciate other things in their lives. Questions or comments at this point? I know I'm barreling through. Okay. So a trance diagnostic intervention, which is what mindfulness and modification therapy, MMT, is trance diagnostic for behavioral dysregulation. And it might increase the effectiveness of treatments for behavioral dysregulation for a number of reasons. First, many people with one area of behavioral dysregulation have another. So they overeat and they also smoke, or they drink and they also smoke. Or they have one that's their main area, but when it gets addressed, they move to another. They stop drinking, but they start smoking. They start smoking, they stop smoking, but they start overeating. So perhaps there's this common construct: difficulties experiencing and tolerating uncomfortable or distressing emotions, thoughts, and urges that explains this overlap of dysregulated behaviors. And so perhaps a mindfulness focus may address this construct underlying this array of dysregulated behaviors. And so perhaps this treatment could be a standalone treatment for some people, that the behavioral dysregulation is the main thing. It also could be integrated into disorder-specific treatments to make it less likely that the person will segue from one disordered behavior to another. Or it could be a first step treatment, which is how we're using it now. We have all these dysregulated people that have been sort of thrown out of and or dropped out of most treatment throughout the city of New York. And they come to us for 20 weeks. They actually get to the point where their dysregulated behavior is more under control, and then we actually refer them to other therapies that they're able to then tolerate. And speaking of trans diagnostic treatments that focus on mindfulness and target dysregulation, I will now talk about MMT and tell you the results of 2 trials of MMT targeting a population with multiple forms of dysregulation. Women with substance use disorders and aggression. And in both studies, FYI, 90% of the women or more met criteria for borderline personality disorder, although that was not a criteria for admittance. It just happened that when you actually get women who have substance use disorders and aggression, that a lot of them have BPD. And then if we have time, I'll discuss just a few components of MMT. So MMT is a 12 to 20 week treatment which can be administered in individual or group sessions. It draws heavily from mindfulness-based relapse prevention. How many of you know, are familiar at all with some of the treatments, mindfulness-based stress reduction, mindfulness-based cognitive therapy for depression? So this draws from mindfulness-based relapse prevention, which Alan Marlatt and Sarah Bowen created at the University of Washington. However, MMT is very different from the standard mindfulness-based treatments because they tend to be pretty didactic. They're 2-hour sessions, they're 8 weeks, clients come in, and it's a leader that leads people through mindfulness exercises. And while there is some talking between the participants and the leader, it's more, it's in a setting sometimes sort of like this. There can sometimes be 20 people that are in the group. So it is very didactic, it's not individualized, it's not hugely interactive. MMT is very individualized, it's very interactive, and it's tailored to the values of the particular client. MMT also incorporates principles of dialectical behavior therapy, that whole balance between acceptance and change, and motivational interviewing and emotion focused. There's 4 main areas of focus. The first, just to foster the ability to experience and tolerate the present moment without feeling the need to engage in behaviors to suppress the moment if the moment is uncomfortable. We have some just neutral mindfulness exercises. We have in session the client visualize and really get into a situation that is likely to make them very angry and or bring up urges or whatever their target behavior is. And then we lead them through mindfulness exercises to experience the urges and the emotions on purpose for a while without acting on it. We have mindful regulation of emotion, things like urge roadblocks to help the client engage in value behavior despite urges. I just realized, did you guys are supposed to have handouts with all of this on it? You don't have that? Okay. You got it? Okay, cool. So I'm not going to go into all of this. You'll have the handouts if you want to pour over it later this evening or over the weekend, which I'm sure you will. With all of your free time that you probably have as a trainee here.
I'm sorry, how do you go about having somebody or having a group of people do this mindfulness exercise where they're actively trying to think of something that's kind of going to piss them off or maybe make them feel upset, and then how do you bring them down from that, or what is the conclusion of the exercise, I guess?
Well, we don't start that. That's not within the first couple of sessions. So first we've actually done a few sessions. We've developed rapport. The relationship with the therapist is hugely important, and clients tend to love the therapist because the therapist is very validating, very finds like the kernel of truth, things about the client to affirm. In fact, one of the goals of the first session is the client leaves feeling better. I say herself because we've tried this mainly with women, but better about herself than when she came in. So one time we did it with women, court referred, and the therapist would focus on the fact that, you know, even though you're court referred and don't want to be here, you actually are coming in and being polite to me and actually talking to me, and that shows something, you know, about you, impressive about you. So there's this really nice relationship between the therapist and the client. By the time we do that, where we get them to be, first of all, for these clients, it's really not hard to get them to be pissed off, and often, even in session, when we're not trying, they're pretty pissed off about something that recently happened, or because the security guard wouldn't let them walk in without signing in, or for various things. So a lot of times it's almost baseline for them. But by the time we do that exercise, we've actually talked about the fact that part of what we're doing is purposely, and we've given them exercises to purposely experience these emotions without acting on them, because power is big for these clients, and we talk about your emotions have power over you. Your emotions have control over you. And in fact, those people that piss you off so much, by losing it around them, you're giving them the power. They have control over you. We're going to help you take back your power so they can't control you. They can't control your behavior. So we've done all of this and we've explained it. So we bring them to the session and we say, you know, so we're purposely going to get you to something that upsets you. And so they do, and often they will say, you know, on a scale of 0 to 100, we'll actually say, you know, so how upset are you now? And a lot of times they'll say 90. We've had like 120 on a scale of 0 to 100. And then we do take them, there's this incredible exercise that I wish I could take credit for, but Sarah Bowen created it for Mindfulness-Based Relapse Prevention. It's called the SOBER, and it's in the slides, but it's an acronym, and it's basically being aware of and observing various thoughts and doing things to watch the waves. But anyway, we take them through that, and we say, by the end of this exercise, that number may decrease, or that number may be the same, and if so, it's totally fine either way, because you haven't acted on it. You know, you're learning to actually tolerate it. You're learning to let it not control you. And we tell them, we have all sorts of metaphors, and we say that pressure that you feel when you get upset, we liken it to like putting the lid on the boiling pot. And we say that will release with some of these exercises. We say it's like you poke a hole in the lid, and so let some of the steam out so the pressure decreases. But the only way to do that is purposely experience the emotions sometimes when they're up here without acting on them. So we've really set it up by then. And a lot of people question this part and say, well, don't your clients like totally lose it at that point? And what tends to happen is when we go through the mindfulness exercise after them really experiencing them, afterwards they tend to say that their distress has decreased at least somewhat. So the stress, you know, is like this combination of anger and upsetness and just And they tend to say, in fact, I don't know if anyone has ever said that it hasn't decreased at least a little bit, but sometimes it's still pretty high up there. And we say, you know, I'm sorry that I know it feels incredibly uncomfortable, but, you know, unfortunately, it's probably not all that rare for you. There's probably a lot of times you feel like this even when you're not trying, and they say yes. And we say, and we talk about how to handle it when they leave. So they don't always leave with it, you know, back down at 40 or even 50. And we're sort of okay with that. And we actually haven't had, you know, any negative results from it. But that's part of what we're teaching them, is that these emotions aren't dangerous, because that's sort of what they thought all their life, that this is dangerous. And if I start getting angry, you know, I'm going to do something. You know, almost like the emotions and the behaviors are 100% connected. And what we're teaching them is they're not. Like, they don't have to control you. You can take back your power.
I just want to clarify first. Is self-compassion understanding different from self-validation?
It's very similar, although, so the self-validation, So the self-validation, there are various steps to it, or at least what I've seen for it. So I guess self-compassion and understanding isn't, we don't teach it quite as structured as the self-validation.
Self-image is not structured. Well, maybe we're talking about with
Yeah, so I was talking about in the DBT that I...
Well, but self-validation is pretty much, it makes sense that I'm upset because...
Yeah, that sort of thing. That sort of thing, yeah. Any other questions? So we have mindful regulation of emotions, we have mindful communication skills, and integration of all skills. We have lots of home practice for these extremely dysregulated people. And just to let you know, so some of our recent clients, one had restraining orders against her in 3 colleges in New York State that if she walked on campus, several of them had been thrown out of DBT programs in New York, and actually we're told if you contact me again, we're going to have to call the police because they found their therapist on Facebook and all these things, and we're posting all sorts of things about their therapist online. So we've got some pretty dysregulated clients. We have lots of home practice. We definitely do shaping, and we definitely use the therapy relationship to get them to start doing these things. But we give them CDs, so we don't expect them to go out and do this mindfulness practice on their own. We give them CDs that guide them through practices. And at the beginning, the person talks the entire time through the CD, the person that's on the CD. So it's very guided. And so, they're not having to sit for even 30 seconds without any sort of vocal guidance and just be aware on their own. The CDs are anywhere from 11 to 17 minutes. We change the CDs throughout the session. We actually add more. They get to keep all the CDs. So they have to do, or they're asked to do, to listen to 1 CD every day, and the more CDs we give, they get to choose between the various CDs. Most people have a favorite. They have a brief daily log just so we can know what's going on during their week, but also so they can take 5 minutes to just be aware of what they felt that day. They have daily informal mindfulness activities, such as we start that in week 2, such as the sober breathing space, which takes about 2 to 3 minutes a day. We assign that the first week along with the body scan. Body scan first week, second week we add the sober, which takes 2 to 3 minutes, and they do that twice a day. They can be doing other things while they do it. Starting the 3rd week, we have them do that 3 times a day. In the 5th or 6th week, we ask them to do 1 pleasant, goal-directed, or valued activity per day. Now, it can be something that they already do, that they just take time to be aware, even if it's just for a minute, that I actually enjoy eating this food, or I'm actually enjoying walking through this park, or I at least could enjoy it. Maybe I don't right now, which we tell them that's okay. You're not supposed to force yourself to enjoy. But we also encourage them at least sometimes to do things that they wouldn't just normally do in their everyday, to sort of actually retrain themselves that they actually do deserve to have some pleasure in life, or do deserve to do things that are fulfilling. And then sometimes we have additional weekly activities. It's different from NEA.BPD, Mindfulness-Based Relapse Prevention. I sort of already said this, but the focus on the relationship, identifying and moving toward individual values, reflections and affirmations, and customized and interactive. It's different from DBT in that there are structured daily mindfulness practices with CDs and some without throughout the entire treatment. Mindfulness is a core part of every exercise. It's not just one component. There's formal mindful exposure in session. We don't break down mindfulness into components. And it's way, way simpler to learn and practice. There are way fewer skills for the therapist and for the client to learn. And it's also, we don't say that we're curing BPD. We say we're actually, we're focusing on the dysregulated behaviors. So this is all well and good, but will clients with BPD really do formal mindfulness practice? And can anything like this really work? Oh no, I'm close to out of time, so I'm gonna go really fast. So we've done it with 2 trials with women who have aggression and substance issues, basically because that's what we could get grants for. The first was 14 women. It was pre-post. They were all court referred. Retention was 93%. Average for this population is around 50 to 70%, although most studies find 50. Significant decreases in drinking days, drinks consumed per day, days of drug use and physical aggression, and all effect sizes were large. On a scale of 0 to 10, participants were asked when they were leaving how helpful the treatment was. People were rated it as highly helpful. When asked why they answered the way they did, and then we just left it open-ended, and this was anonymous, 62% wrote feeling like a better person or liking self better. 54 wrote improved relationships with family members or partner. 54 receiving compliments from others about changes in behavior. And 23 improved relationships with God or the church. We don't focus that, but we focus on what they value. So if they brought up that that's one of their values, we focus on it. Clients suggested that the treatment would be longer, and remember, these were clients that were court referred, so they didn't want to come to treatment to begin with. And clinical observations suggested that it should. Lots of limitations. So we made it longer, and we did some preliminary results to get a longer manual. It's now 20 weeks. The 20-week version, so far we've done MMT with 11 clients, and we have 4 in treatment. We also have a comparison condition, CBT treatment as usual. And these clients are not mandated. They tend to be sort of the severest of the severe. So far, retention in this is 80%, which is still significantly larger, especially when you see that almost everyone we've gotten are people that have dropped out of and or been kicked out of other treatment centers. Preliminary evidence, significant decreases in, again, drinking, drug use, physical aggression, and also we've given more measures this time. There appears to be decreases in emotion dysregulation, depressive symptoms, anger, hostility, trauma symptoms, BPD features, BSI global severity of functioning, and increases in mindfulness. We haven't yet analyzed the results of MMT versus the CBT condition. We do know that the retention in our condition is significantly larger. We've also trained other therapists. I'll end in like a minute. We've trained other therapists, none of whom have had mindfulness experience before, and we didn't require them to have a mindfulness practice because we wanted it to be generalizable, which actually makes it more likely to be generalizable, although it was very scary for a while when we first got these people in there. They've all become inherent, and I already said that next part. We've also done case studies with other populations and had very good results. And we're about to start a group-based MMT in addition to individual therapy for some people. So these are our conclusions. I really wanted to tell you a little more specifics about some of the things we do in MMT. Unfortunately, I don't have time. But thank you for being a nice audience. And if anyone, my contact info is on the handouts, and if anyone has any questions, feel free to contact me. Thank you.